session, sir.
Yes, sir, and please start.
Welcome, Kanan, sir. So, I am very glad that we have started the next session of our interdisciplinary forum where we will be presenting a case. And today we have a moderator, Dr. Arun Vishwanath, who is a renowned endocrinologist in the city of Tirunelveli. Actually, he has done some lectures for us also. PG Suda being no stranger to him. So I welcome you, Dr. Arun Vishwanath, as well as I welcome our Dr. Kannan, sir, the consultant neurologist in Thoothukudi. I welcome you both and hope we can start with the presentation since it's becoming late.
Good evening, sir. So I'd like to start.
Thank you. Sir, just one query, sir. The presentation, what is the flow of the meeting, sir? The presentation will be completed and we should intervene at the end, or?
You can discuss then and there. In between, you can discuss. In the presentation, you can stop in between. For example, you'll be presenting history of present illness. If you want to discuss about some symptomatology, you can stop. If you feel that it is discussion is not needed, you can allow the presenter to present. Or if you are, if it's okay for you, you can discuss at the end after a complete presentation. That is your wish, sir. But neurologist is here, so I expect some discussion on the type of seizure and the secondary seizure, some 5 to 10 minutes. So some discussion may happen in the history itself by neurologist. And I think your role and your place is at the end of the presentation. That is the endocrinological part. I think so.
Good evening, sir.
Good evening. Can start with the presentation.
Start.
A 32-year-old married female, homemaker by occupation, belonging to belong to middle socioeconomic class, both up, involving movement of involving both upper and lower limb. Not audible. Sir, am I audible, sir?
It's audible.
Yes, go on.
A 32-year-old female.
Hello, Napoleon.
Network has been lost, I think so. Some other PG can present, whoever available, the PPT in our Osler hall.
So some other PG can present even looking at the presentation in your cell phone. There is no need to project the slides if it is getting late.
Any PG available in our Osler hall? I think PPT is visible in the screen. You can present from the screen.
Sir, am I audible now, sir?
Yes, present.
Sorry for the interruption, sir. The
Okay,
patient was
proceed,
apparently asymptomatic and
Start.
okay, sir. Patient was apparently asymptomatic until around 5 p.m. on the day of admission, when she suddenly developed abnormal involuntary movements involving all 4 limbs. The episode was generalized in nature, associated with upward rolling of the eyeballs and tongue bite, and lasted approximately 5 minutes. Following the episode, the patient experienced a period of post-ictal confusion lasting several minutes, after which she gradually regained her baseline sensorium. There was no history suggestive of focal onset of seizure activity. The history of presenting illness: there is no history of aura, no history of headache or vomiting, blurring of vision, no history of fever or recurrent infection.
Yamant, mute yourself. Everybody, please mute yourself.
So, what is the seizure semiology in this case? What is the seizure semiology in this case? So, what is seizure semiology?
Final year students can also answer. Final year postgraduates.
So, what is the seizure semiology? So, this is the semiology. So, once you are discussing the seizure, what is the course of the seizure? It is otherwise called semiology, seizure semiology. So, seizure semiology is useful to diagnose and localize the lesion in the brain or anywhere. So, where you are localizing this case? So, abnormal involuntary movement involving all four limbs. So, it is a GTCS. Okay. So, GTCS
Okay, sir.
with the loss of consciousness. So, where you localize the GTCS and loss of consciousness. So, loss of consciousness is diffuse cortical involvement. Okay, diffuse cortical involvement, and also RA system is affected. Okay, so this is not a focal. This is diffuse. GTCS means this is usually a diffuse cortical involvement. So, what will be the cause for cortical involvement? You have to go through the other histories and findings. Okay, tell you. You go through history.
History of presenting illness. There is no history of aura preceding the episode, no history of headache or vomiting or blurring of vision or fever or recent infection or no history of recent head trauma.
What is the usefulness of headache in this patient?
There would be increased ICT.
Young female presented with the seizure, headache. What do you think? What type of headache you are expecting this patient?
It would be CVT, sir.
What type of headache? What is the classical headache? So you must not tell this is not no history of headache. What type of headache you are expecting? Okay. So history of throbbing headache. Okay. So history of throbbing headache you are expecting. Okay. Go through it.
There is no history of vomiting, no history of blurring of vision, no history of fever, no history of a recent infection, or no history of head trauma. And there is no history of involuntary maturation or no history of involuntary defecation, no history of limb weakness or facial deviation, no history of speech disturbances or sensory loss, no history of gait instability. There is no history of corporeal spasm. There is no history of muscle cramps, no history of laryngospasm, no history of cough or breathlessness or chest pain or palpitation or no history of orthopnea. There is no history of paroxysmal nocturnal dyspnea, no history of decreased urine output.
Oh. So what is the use of these histories? So no history of cramps, no history of laryngospasm. What history you are expecting from this?
Regarding carpopedal spasm, there is hypocalcemia can cause that seizures, sir. And muscle cramps also, electrolyte imbalance like hypokalemia could be the cause, sir.
Okay, go through.
What about laryngospasm? Why was laryngospasm asked in that patient?
Sir,
no, you must have thought of something before asking that question.
What is Sudappa? What is Sudap? Anybody tell?
There could be sudden unexpected death in epilepsy, sir. So laryngospasm history is asked, sir.
Okay, some autonomic imbalance will be there that may produce sudden, unexpected, unexplained death. Okay.
Related to this patient specifically, doctor? Because sir, we all already know the diagnosis now, so that's why I'm here. Otherwise, Kannan sir will be there. Is there any relevant to this patient?
Hypocalcemia is metabolic cause of laryngospasm, sir, also.
Yeah, I mean, most of the patient usually have laryngospasm. If you specifically go back to any patient who have undergone thyroidectomy at the post-op hypoparathyroidism, they invariably will have new onset bronchial asthma or new onset COPD. They might be following pulmonologists for a long time. So that is one history that's quite common actually, but not very appreciated in routine practice. And so once you correct that, fix that hypocalcemia, generally the respiratory part goes away. So it was not there in this patient.
Okay, sir.
No, I am asking you, was it there or
No,
was it not there?
No, sir. Okay. No, sir.
Okay.
So there is no history of a paroxysmal nocturnal dyspnea, no history of reduced urine output, no history of pedal edema or abdominal pain, no history of diarrhea or constipation, no history of jaundice, and no history of significant weight loss.
So again, and sorry for interruption. Why did you ask for abdominal pain, diarrhea, and constipation in a patient with seizures?
Sir, hypocalcemia can cause hypercalcemia can cause abdominal cramps. GI motility.
Hypocalcemia can also cause cramps. Why do hypocalcemia causes cramps, abdominal cramps?
Sir,
why do hypocalcemia causes abdominal cramps or abdominal pain?
Sir.
Other final pages, please answer the question.
Yeah, probably it seems like 1-to-1.
1-to-1. It should not be 1-to-1. It will be interactive session. All final years, you can unmute and answer the question asked by moderator.
Hypocalcemia increases the nerve excitability, sir, neural excitability.
Which excitability are we talking about when we talk about abdominal pain?
Sir, regarding abdominal pain.
Yeah. And why do hypocalcemia causes nerve hyperexcitability?
Sir, in action potential, calcium inflow is very important for the
calcium is an essential part of neurotransmission. Calcium is an essential part of muscle contraction. So when calcium goes down, we should be expecting hypoexcitability. No, why is it happening in the other way around? Anyone? Why are we seeing hyperexcitability in hypocalcemia when we know physiologically calcium is involved in every step of nerve transmission as well as muscle contraction? So naturally, when calcium goes down, we should be expecting hypoexcitability, no, but it's not there. And similarly, in hypercalcemia, we should be expecting hyperexcitability, and exactly the reverse happen. There's a phenomenon explaining this one. Anyone? PGs? What is calcium paradox? That is the answer. There's when we talk about calcium mediating calcium mediating muscle contraction, calcium mediating nerve transmission, we are usually talking about the intracellular calcium. But when we generally see this hypocalcemia or hypercalcemia patient, here we are talking about the extracellular calcium. That is the difference. Actually, the intracellular calcium part is the one that directly mediates all this phenomenon, while your extracellular calcium actually acts in the opposite direction. So it tends to lower the excitability, tends to promote the potassium channel effect. So that's the difference, the calcium paradox. That's why we see in hypocalcemia where we get lower extracellular calcium, there'll be more excitability, and in hypercalcemia again we are talking about extracellular calcium, there'll be hypoexcitability because we are not talking about the intracellular calcium. So that phenomenon is calcium paradox. That explains almost all the history that you're trying to ask. With the abdominal pain, we are talking about vagal nerve hyperexcitability, and even in subsequent slides we'll see what other form of excitability that you have elicited in this patient. You can proceed.
Okay, sir. So next to past history, sir.
What is the significance of abdominal pain with the seizure, pa?
Other causes.
What are the abdominal pain with the seizures? Young age, abdominal pain, seizures. What do you think of?
The great muscaratum.
Eclampsia.
Porphyria.
Connective tissue disorders, porphyria, connective tissue disorder. These are all very common. Okay, young females think of connective tissue disorder and porphyria. So that also
Okay,
will
sir.
produce neuropathy and also seizure also. Okay, go through it.
Okay, sir. Past history, sir. The patient was diagnosed with a papillary carcinoma of the thyroid approximately 1 year prior to the current presentation. She underwent total thyroidectomy with a modified radical neck dissection at that time. The postoperative period was uneventful. Subsequently, she underwent radioactive ion ablation therapy for residual thyroid tissue, receiving 3 cycles, the last cycle being in January 2026.
But it cannot be 3 cycles. Radioiodine, probably either you are mistaken or the patient is mistaken. Radioiodine ablation is not given in 3 cycles. It's not that usual radiotherapy or chemotherapy. They used to give one tonic. First, they used to do a scan to find out if there is any residual thyroid tissue. They used to give 1 to 2 millicurie. Then, for if there is a residual tissue, they go for radioactive ablation, where they give some 100 to 150 millicurie. So the patient used to drink the tonic, stay in isolation, and repeat the scan. That's how it goes. It cannot be 3 cycles. Probably she would have received only 1 cycle. They might have confused, and they might have confused you as well. It cannot be
Okay.
3 cycles.
Okay, sir. Following surgery, she was advised lifelong thyroid hormone replacement therapy with the tablet thyroxine 150 micrograms once daily, along with the oral calcium supplementation. However, the patient admitted to poor compliance with both medications over the past several months. She also failed to attend scheduled follow-up visits after completion of radioactive iodine ablation. There is no previous history of seizure disorder or a cerebrovascular accident, head injury, meningitis, encephalitis, tuberculosis, CKD, or a chronic liver disease, diabetes mellitus, hypertension, or bronchial asthma, CAD, or psychiatric illness. There is no previous history of hospital administration for similar complaints. Drug history: the patient had been prescribed a tablet thyroxine 150 microgram once daily and oral calcium supplementation following thyroidectomy. Medication adherence has been poor with frequent missed doses. There is no history of intake of alternative medications. Menstrual history are regular with a normal flow. There is no history suggestive of abnormal irregularities during a postpartum or pregnancy or menstrual cycle. Obstetric history is unremarkable, sir.
Any past
There is
history of LOCPA? This patient?
no, sir.
Actually, this patient I seen, there is some past history of LOs. Okay.
What about history of malignancy in the past? I mean, family history. Have you got to family history or no?
Yes, sir. There is no family history of seizure disorder, thyroid malignancy, or endocrine disorders, or metabolic disease, sir.
What kind of other malignancy that you would specifically look for in a patient with a thyroid carcinoma? What other family history that you are trying to look? It need not be mentioned. If you could think of something, other malignancies in a patient with a papillary thyroid carcinoma in family.
Men's syndrome,
Which men specifically?
type 1, sir.
No. Type 1, we don't get PTC. Men too, that red gene mutation can cause familial
Okay,
follicular or papillary thyroid carcinoma. What other malignancies unrelated to thyroid, unrelated to endocrinology? Other malignancy, familial malignancy that you could.
pheochromocytoma, sir.
Colonic cancer, familial adenomatosis polyposis is one inherited form of papillary thyroid carcinoma where you get familial history of colon cancers. Any other
Okay, sir.
inherited syndromes, malignant syndrome that is associated with papillary thyroid carcinoma? Anyone? You see, you don't seem to have any friends. Nobody is coming to rescue you.
All are taking notes for your notes for your
Or like
information.
us, they just switch off everything and just for namesake they might be there. If
No.
Arun Kumar sir could ask any,
That's
because we don't know the names, if you could ask someone's name particularly.
Actually, they will be sitting on their phones and they'll be listening from the common room. We have a common room,
Okay.
demonstration room.
Oh, fine.
So possibly that may be there. Still, RPGs are learning, so they may be little reluctant in answering. That's all.
Cowden
Just
syndrome,
like
sir.
Cowden is there. You could have Googled in the short time. Other syndromes, any other syndrome? Cowden, Turcot,
So
Cornish
Werner's.
complex. There's a long list of malignancies that can run in family. That includes
Okay.
papillary thyroid carcinoma as well. Specifically from Thoothukudi Medical College, I got nearly 3 or 4 familial PTCs. So that's why I mean, one patient of Gardner syndrome as well. We recently came from Thoothukudi Medical College. So all these things are there. When we are doing the genetic sequencing in most of the FNAC slides, and we are coming across many dicer1 mutation in our population. So that also causes familial PTC. So we should be remembering all those things. Then we can proceed.
Okay, sir. So personal history: patient is a homemaker residing with her family. Appetite was normal prior to the present illness. Sleep pattern was adequate. Bowel and bladder habits were normal. She consumes a mixed diet. There is no history of tobacco use or alcohol consumption or recreational drug abuse.
Again,
So,
just to poke into the history, any patient, because the patient obviously had hypocalcemic seizures, it's highly unlikely that the patient did not had any symptoms or signs of, symptoms of hypocalcemia before presenting with seizures. That can happen only when they have a lifelong hypocalcemia in some form of genetic hypocalcemic syndromes, where they used to gradually develop hypocalcemia and they don't exhibit any symptom. But in our case, where there is a definite trigger before developing, because that is a post-op hypoparathyroidism, the patient would have developed hypocalcemia only for the last 1 year or so. So definitely there might be some symptoms, but apparently your patient did not concede to any of the symptoms, especially poor appetite and lack of sleep. Altered bowel habits must be there in any form of acquired hypocalcemia. It cannot be. I mean, all the things are normal. It can, and one fine day or one fine evening, the patient presenting with seizures cannot be there. Probably the attendant might have given a history considering the patient was very sick. So probably that's why all your histories have been negative.
okay, sir. That was occasional muscle cramps was there, sir. There, but
Yeah, but you could have said it's a positive history. It's a bit strange that the patient had only seizures and no other manifestations of hypocalcemia for the last 1 year. So that cannot be that. That it's not technically not possible. That includes this appetite and sleep is heavily impaired in this patient, hypocalcemic patient, acquired hypocalcemic patients. Fine.
okay, sir.
Can proceed.
So summary: a 32-year-old female homemaker, a known case of papillary carcinoma thyroid status post total thyroidectomy with modified radical neck dissection and 3 cycles of radioactive iodine ablation on irregular thyroxine and calcium supplementation with poor follow-up. Presented with the first episode of GTCS associated with the dung bite and post-ictal confusion without fever, trauma, or focal neurological deficit or other systemic complaints.
What is
On
symptomatic
general,
seizure, Pa? What is symptomatic seizure?
Sir, symptomatic seizures, which are a seizure that result of underlying cause affecting the brain, sir. Any underlying cause, common causes like a head injury or trauma or a brain infection, tumors,
So metabolic
fever,
disorders
alcohol,
also.
metabolic disorders like low sugar, hypoglycemia, hyponatremia, or in CKD or CLD patients, sir, or hypoxemia.
What is the need for this classification as symptomatic seizure? What is the use?
Sir, to identify and treat the cause, sir. Underlying cause.
Underlying cause. So it is not idiopathic. So usually seizures are idiopathic is the common. Okay. So these are due to secondary cause. As Rajavel sir told, it is a secondary seizures. Or otherwise you can tell it's a symptomatic seizure. So symptomatic seizures. So how to treat the symptomatic seizures?
Sir, we have to underline the. I have to identify the underlying cause, sir.
And then seizure control. Seizure control.
Anti-epileptic, sir.
Anti-epileptic. So how long you can continue the anti-epileptic for these patients?
Sir, seizure-free episode for 2 years, sir.
Yes. So not like that. There's a routine. Patients are treated like that. Here, if you treat the underlying etiology, you may stop within short period, 3 months, up to 3 months, 6 months, you can stop. Okay.
Okay, sir. Okay.
And pertaining to our case, what kind of anti-epileptics to be avoided?
Sir, phenytoin should be avoided, sir.
Other things, the classical anti-epileptics. Why phenytoin should be avoided?
Sir, it causes a vitamin D deficiency, sir.
How?
Calcemia.
No, it acts at a multiple level to cause to precipitate hypocalcemia. Phenytoin directly impairs calcium absorption in intestine. Then again, by it induces vitamin D, 25-hydroxy vitamin D conversion to the inactive form rather than converting into the active form. And phenytoin directly impairs bone metabolism, and that bone resorption mediated calcium release is also impaired. So it acts at multiple places to cause hypocalcemia or precipitate hypocalcemia in a patient who has an underlying hypocalcemic seizures. Other anti-epileptics to be avoided in such cases.
Phenobarbital, carbamazepine.
Fine.
Okay, sir. So general examination on a presentation, patient was conscious, sir, alert and cooperative, moderately built and moderate nourished, afebrile, fairly hydrated, no dyspnea, no tachypneic, no pyloric or cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema. And there was a thyroidectomy scar, well-healed thyroidectomy scar present over anterior neck. So there was a feature suggestive of a previous neck dissection noted, sir.
Any,
so higher mental.
Can you go back to that slide? Yeah, this is your patient, which everything is, fine and rosy. But if you're looking for any specific signs of hypocalcemia in general examination, what would you look for? What can you expect in a general examination of a patient with hypocalcemia?
So like tachycardia, palpitations.
General examination.
Sweating.
General examination.
So tremors.
Hypocalcemia.
Confusion.
Yeah, if you start from the general condition, generally any patient who has severe hypocalcemia, probably you might be showing it in the next slide. The build may not be normal. They will have some form of malnourishment. And again, they may look pale actually. The hemoglobin might be normal, but they still look pale. So that is one finding, general examination finding. And what about the teeth, nails, skin, all those things in your patient?
Normal, sir.
Normal, but usually in hypocalcemia, we expect findings. What kind of findings that you would expect in a patient with hypocalcemia?
Sir, dry, coarse skin, brittle nails, hair loss.
Nail?
Ridging of nails, sir.
Onycholysis might be there. Onychomycosis might be there. Okay. And hair thinning might be there, as you said rightly. What about teeth?
Sir is asking for especially for teeth.
Okay, sir. It's a defective enamel, dental caries, brittle teeth.
Was it there? No.
No, sir.
If those things are actually telltale signs of long-standing hypocalcemia, which probably in your patient, because the history is for 1 year only, but may not be apparent. But if those things are there, you could think of long-standing hypocalcemia, cataract, this enamel hypoplasia, skin changes and nail changes are there. You could literally say the patient has long-standing chronic hypoparathyroidism, chronic hypocalcemia of some cause. Next.
Okay, sir. Higher mental function, patient conscious, oriented to time, place, and person, attention normal, memory normal, speech normal, comprehension fluency intact, mood affect normal. So cranial nerve examination, sir. So all 12 cranial nerves.
Again, in higher function, again, because I'm tunneled into hypocalcemia, I'm supposed to say something about hypocalcemia. I know, That's not the way the case discussion goes. But higher function, what do you think of? What can you expect in a patient with hypocalcemia? Higher function.
Psychiatric illness also expected, sir.
So,
Other confused.
What is brain fog? Brain fog. That is a classical way to describe the mood and the behavior of a hypocalcemic patient. Brain fog. It's not I'm not asking about sort of definition, but it's a catchy phrase that people use while describing the neuropsychiatric manifestation of hypocalcemia. They'll not be able to think properly. And one another case of brain fogging will be seen in hypopituitarism, Sheehan syndrome patient. If you ask their name, they'll think over a period of time and before they answer the question. So those things are brain fogging is classical of hypocalcemia.
Okay, sir. Right. So cranial nerves.
Or you can proceed to next thing.
So cranial nerves are normal, sir. Normal, and no abnormal detected. Motor system, muscle bulk normal, fasciculations absent, involuntary movements absent. Upper limb power, tone and power, both upper and lower limb.
General examination Trausi signs, Chwastak sign எல்லாம் பண்ணி பாத்தியா தம்பி எது இருக்கா?
Next slide I will shown in the next slides, sir.
What do you expect in all these things? The previous slides. Motor function, what is expected in a patient of hypocalcemia, not in your patient. Again, for some reason, everything is normal in your patient, despite hypocalcemia. So I'll ask generally, what kind of findings that you would expect in a motor system examination of a patient with hypocalcemia? What will be the bulk of the muscle, tone of the muscle?
Sir, episodic weakness.
Why episodic? Hypocalcemia has always been there. Why should it be episodic? You expect some kind of, extrapyramidal side effects. Why does extra EPS occurs in hypocalcemia? How it occurs? Because you have said it's not there. You look for that sign, extrapyramidal symptoms.
It is intracranial calcification
due to hypocalcemia, right?
Yes.
That where do you expect calcium deposition in hypocalcemia?
Basal ganglia.
Basal ganglia calcium.
What is Force disease, ra? What is Force disease?
Sir, it's a intracranial calcification disease, sir.
Where it is calcification occurs? It is in the bilateral basal ganglia.
Basal ganglia, thalamus. Yes, sir.
Bilateral basal ganglia, caudate nucleus. Okay, so Force disease, idiopathic conditions.
Why does it occur only in basal ganglia, not in other sites? Which year are you from, doctor?
Second year. MD second year. He is second year.
Oh,
sorry, sir.
Why it occurs specifically in basal ganglia? Why not in other sites? So please look into that answer. Why it occurs?
Which of the areas are highly metabolic region in cortex, in brain?
Due to basal ganglia has a rich vascular supply, sir, and high metabolic demand.
So
and PT1 receptors are quite common there.
Sorry, sir.
Yeah, high metabolic rate,
sorry, is asking what
blood flow, and there is PTH1 receptor will be more expressible at that.
So mitochondria is predominant there. Okay, mitochondria also predominant. So because of that, more metabolism occurs there. So hypoxia, hypocalcemia, carbon monoxide, all will occur. Toxic regions are mainly concentrate on basal ganglia. So that will produce the basal ganglia symptoms in the form of rigidity, in the form of tremor, extrapyramidal symptoms will be predominant. Okay. Okay, go through it.
Again, the deep tendon reflexes may not be normal. I believe 2+ is normal. We expect it to be kind of hyperreflexia. So it may be higher than 2+ in a patient with such a severe hypocalcemia. Then,
okay, sir.
Next.
Okay, sir. A sensory system, The touch pain temperature was normal. Vibration, position, and cortical sensation were intact. Extrapyramidal and autonomics. There is no rigidity, no tremor, no bradykinesia, no involuntary movements. There is no incontinence, and there is no other autonomic features. And regarding signs of hypocalcemia, sir, Chopstick sign was positive, Trausive sign positive, but there was no history of corpopedal spasm, sir.
So we'll stop at this slide for a slight moment. Chopstick sign, where do you elicit? Usually the chopstick sign.
So over
And
the
what other sides can you elicit chopstick sign?
so usually we check over the neck of mandible region, sir. So we tap over the neck of the mandible to look for excitation. When we do tapping over the
No, it's not neck of mandible. Probably there is other landmark. I'm not sure
tragus,
exactly,
sir.
but I don't think that they calculate when they say the neck of mandible. It's probably the unit calculate from the tragus, and it's probably the something to do with the zygotic arch. It comes somewhere around here. The exit of facial. Now, is there any other place where you can elicit chopstick sign?
So we can check at the angle of the mouth.
Yeah, it's somewhere. It's between the LNAC and this chopstick side elicitation side B, this side A. And for betterment of for future presentation, we can always say there is a grading of chopstick sign. Do you know that? That can actually tell you about the severity of hypocalcemia. What are you trying to elicit with chopstick sign?
Sir, hyperexcitability of the nerve, sir.
Which nerve?
Facial nerve, sir.
Facial. There's somebody sitting near you is probably speaking. Facial, yeah, it's a sensory now. We are trying to elicit sensory hyperexcitability. Do you know the grading? There is a grading. Grade 1, 2, 3, probably 3 or 4. In 1, actually, there will be only twitching of angle of mouth. In 2, twitching of angle of mouth as well as AL and AC. In 3, all these 3 regions, the orbicularis, oculi, LNSA, and angle of mouth will twitch. And in 4, there will be hemifacial twitching. So, if you could remember, you can say what kind of twitching, chopstick sign grading that your patient had.
So, was a grade 1, sir. Facial muscle twitching.
Grade 1. Okay, probably the patient might have, because of seizures, they might have lost consciousness. The grading might have gone down. Otherwise, we expect it to be higher in a patient with seizures. It will be grade 3, or sometimes hemifacial twitching is also there. And there's a general dictum that any patient who is going for surgery, thyroid surgery, we should actually document whether the patient has chopstick sign or not prior to surgery. Why do they do that? They practice routinely in all the central institutions. Prior to thyroid surgery, you have to document in the case sheet whether the patient had chopstick sign or not. Anyone? Why should you do chopstick sign before the patient goes in for surgery? Thyroid surgery. Any guesses?
Bedside.
Why should we document the patient chopstick sign before going for surgery? Can chopstick sign occur in a normal person? Like you and me? It can occur, right? When somebody asks you a question like that, you have to say, yeah, it can occur. The leading question, right? It can occur in 25% of normal individual. Usually, it may not be not more than grade 1, but it is usually seen in even 25% of general population. So, anyone going for thyroid surgery, you have to actually document whether the patient had pre-existing chopstick sign positivity, so that in immediate post-op period, when when you go bedside, you will look for these signs. No, so we can compare with the pre-existing grading of chopstick sign. That's how they work in most of the central government institutions, right? So you have to document. And what about Trousseau sign?
So Trousseau sign positive in this patient, sir. It's a clinical signs of hypercalcemia.
Yeah, again, anything more that you can add to the Trousseau sign? I am glad that you didn't say Trosia said. I was under the impression it's Trosia. It's pronounced Trosia till my MD. Then only I came to know in my DM that it's Truzo, not Trosia. Anything
Okay,
that
sir.
you can add to the Truzo sign to
Sir,
quantitate or to better your finding? There's something called time to Truzo sign. Again, that is an indicator of how you're correcting hypocalcemia in your patient. The time to Truzo sign when for example, initially before correcting your documenting Truzo sign to occur within 10 to 15 seconds. Then you correct with IV hypercalcium, then you can document actually the time to Truzo should prolong as you correct before disappearing completely. So that's a very good actually bedside way of documenting the progression of correction of hypocalcemia, whether it's happening properly or not. So time to Truzo is important.
okay, sir.
Again, what are we trying to elicit with Truzo sign? You said
Sir, again,
with
so
Truzo
low
sign, what
ionized.
are we trying to elicit?
Sir, it's look for the low ionized calcium, sir.
Motor hyperexcitability. With Chowastek sign, we are trying to elicit facial now, the sensory now hyperexcitability. This is a sign of motor hyperexcitability.
Neural. Okay, sir.
Fine.
Okay, sir. And systemic examination, no abnormal detected in the CVS, RS, and per abdomen, sir.
Do you expect anything in CVSRS in this patient?
Sir, tachycardia, sir.
Okay. Respiratory findings we discussed, no? You expect V's in most of these patients. Hypocalcemia, they'll be having invariably V's.
Tachypneic, laryngospasm, tachypneic.
Yeah, wheezing will be there. If you auscultate, you could auscultate wheeze.
Okay, sir. Okay, sir.
Thanks.
Yes, sir. So ECG findings for the patient, sir, on presentation.
You should be telling us the finding. We are very weak with ECG. I am very weak with ECG. Can you just tell me the positive finding in ECG?
It was, sir, heart rate was 90, sir, and abnormal findings.
Yeah, abnormal findings. Because you know the patient has hypocalcemia, that's why you might have
QT
done
prolonged,
it.
sir. QT prolonged, sir.
What are the things that you expect in a patient with ECG findings in hypocalcemia?
Sir, the QT prolongation is most important finding, sir. There will be
Fine.
abnormal or flattened T waves. So ventricular ectopics can be expected, sir, or arrhythmias.
What happens to QRS?
Sir,
QT prolongation is the major finding. QT gets prolonged predominantly because of ST prolongation. Generally, actually, hypocalcemia, unless it's very severe, it doesn't touch the T waves.
okay, sir.
Fine.
No changes.
And in rare cases, actually, hypocalcemia can produce ECG waves just like STEMI, ST elevation, and T wave alternance can also occur.
Okay, sir.
Fine.
Here what T waves, ba? Here what
Sir,
T waves? V5, V6, V4, V5, V6.
T wave inverted, sir. Inverted, sir.
P wave irukappa? P wave kaanume. P wave is present or not?
Sir, long QT near to QRS complex கிட்ட
QRS complex ஓட merge ஆகுதா?
இல்ல சார் மெர்ஜ் இல்லைங்க சார்.
P wave காணுமேடா தம்பி. இல்லையா?
பீக்கு முன்னாடி இருக்கு சார்.
இருக்காப்பா?
அந்த பீக்கு முன்னாடி வருது சார் டி. நெக்ஸ்ட்
பீக்கு முன்னால பீ வந்துருதா
அப்படின்னு சொல்றாரு அவரு. ஆமா எனக்கு அப்படிதான் தோணுது.
லாங் QT-னால உங்களுக்கு
ப்ரொலாங் ஆயிருது. Yeah.
சரி. Okay. Classical long QT. இல்லையா?
If you are working in an ICU and trying to manage a patient of hypocalcemia, you should be having a chart that shows the day, time, calcium, phosphorus, albumin, ALP, QT level, corrected QT duration, and the Chowastek sign, Truzo sign, the grading, time to Truzo. That's how they prepare the hypocalcemia monitoring chart. It's a good practice to follow in during a training period.
Okay, sir.
Next.
And it was another ECG, sir, taken on the same day, sir. Here we have changes in the T wave inversion and QT prolonged, sir.
Fine. Probably we discussed. We can move.
So the event of the event in the hospital, sir, the serum calcium was found to be critically low after admitting the patient. So correlating with the clinical presentation of the generalized seizure activity. So injection calcium gluconate 10%, 10 ml administered IV over 10 minutes under cardiac monitoring, followed by continuous infusion of injection calcium gluconate, which are 5 ampoules dilute 5D administered at 100 ml per hour.
Can you explain that protocol? Calcium hypocalcemia correction, acute correction protocol. You might have read.
The other PGs can answer.
Yes,
Narmada, Dr. Narmada, can answer the question raised by moderator, sir. Protocol of calcium administration. Dr. Manoj. Yes, Narmada, please proceed.
Sir, if the patient is symptomatic, we have to give first initial IV bolus, 10 milli, 10% of 10 ml solution. We have to give IV bolus, sir.
No, I didn't hear. What is it? 10%?
Sir, a 10% of calcium gluconate, 10 ml.
What is 10% of calcium gluconate? What does
10
the
gram.
10% denotes? Calcium gluconate is a very interesting ampule. If you see that ampule, you will learn a lot of things. What does 10% denotes? Yeah. What is W bar V? Most of the ampules they would have written W bar V. What does it stands for?
Weight in
Volume. Right,
volume.
Weight in volume. Why are you hesitating? You're right. What does the 10% says? You can take a guess, educated guess. 10 grams in 100 ml.
Yes, sir.
10 grams in 100 ml. So in 10 ml, how much we are expecting? 1 gram.
1
right?
gram 10 ml.
But how much elemental calcium will be there in 1 ampule of calcium gluconate?
Around 90 milligrams, sir.
Why is it so?
Based on the molecular weight of calcium.
No. In 10 ml, we are expecting 10 grams, no? Sorry,
Yes, sir.
1 gram, no? 1 gram of
1 gram.
this thing. But we get only 90 milligram of calcium in 1 ampule. Why is it so? What is the difference? Why there is a difference? Anyone? Not to target her. What about the calcium tablets that you see, that Shellcal or other brands that you might have heard? There is a difference, no? If you have to see that strip, what kind of calcium tablets that you have in your institution?
Cellcal contains 1250 mg of calcium carbonate, sir.
Okay.
Which is equivalent to elemental calcium of 500 mg, sir.
So that will say what is the percentage of elemental calcium in calcium carbonate? Roughly 40%, right? Similarly, in calcium gluconate, that is the difference. That is an explanation why calcium gluconate, despite having 1 gram in 1 ampule of calcium gluconate, we get only 90 milligram of calcium, elemental calcium. Because it doesn't contain calcium gluconate alone, it actually contains calcium lactobionate as well. So that is the overall volume of that molecule, but we get only elemental calcium, which is a fraction of the total amount of calcium gluconate and calcium lactobionate. Then, after initial bolus, should you give 1 bolus or 2 bolus or many boluses?
Sir, 1 bolus, sir, followed by slow.
So should not we repeat the bolus? Actually, if there is a cardiac compromise or if you are treating some acute event, if the patient is having seizures, you can actually repeat the boluses till the seizure stops. It need not be 1. It's usually 1, but it need not be 1. You can actually repeat the boluses till the acute event stops. And how do you give the bolus? I think that's pretty basic.
Sir, over 10 minutes, 10% calcium gluconate, 10 ml over 10 minutes, sir, under cardiac monitor.
Either we give slow injection or in an infusion, right? Why? What happens when we...
Sir, arrhythmias, QT prolonged.
There'll be
Arrhythmias, sir.
systolic cardiac arrest if you do that right. That's why you give over an infusion. Okay, after the acute bolus, what is the infusion protocol? What is the dose that you follow for the infusion? Once you're done with the acute bolus, you have to give a maintenance, right?
Maintenance infusion, 5 grams of calcium gluconate, sir. In 500 ml of 5D, over with 100 ml per hour infusion, sir.
No, that's you have written, but you have to say in a range, no? It's actually 0.5 to 2 milligram per kg per day. What is the weight of your lady? I mean,
Around
your
50,
patient, sorry.
50 kg, sir.
Around 50 kg. So you have to calculate based on that. It's 0.5 to 2 milligram per kg per
hour.
Yeah, per hour. And once the patient gets stabilized on this infusion, you should initiate oral calcium as well on top of calcium gluconate infusion, so that you will be able to taper off this calcium gluconate infusion, and that should be overlap with oral calcium.
Sir, up to 2 grams daily, sir.
No, is there a maximum limit? I don't think so. Once you do that 0.5 to 2 gram, it will come up to that limit. But is there an end point till which we should run the infusion? Should we have a target? How long when what should be the pace of correction, or how long do you expect the hypocalcemia to get corrected? Actually, there is no, probably I'm asking too many questions. So probably there is no target actually. You cannot correct hypocalcemia with this calcium infusion. That's technically not possible. If you are looking for a normal serum calcium value to be achieved with this infusion, that will take long time. Actually, if you are treating some acute emergencies of hypocalcemia, recovery from that emergency should be the goal. And as soon as the patient is ready to take oral feed, we should switch over to the oral calcium in adequate doses, and gradually you'll have to taper off this infusion rate. And that's where the monitoring comes in. The Chvostek sign, the Trousseau sign, the grading of Chvostek, the time to Trousseau, all these things are the guide and not the lab calcium value. Calcium is highly notorious. What about your calcium values? Is it reliable in your hospital? I have a lab in my in my thing, and I always used to cross check my calcium. It's a very difficult parameter, and my wife is a biochemist. Still, I doubt her. Calcium is a very difficult parameter to measure. What are the precautions that we should take before collecting sample for calcium?
Sir, we should not tie the tourniquet over
Why?
the. It will it will create a condition like trausia, sir.
So what? Let it create trausia. What will happen? It will create local acidosis that will actually spuriously alter the calcium value. That's why we don't tie the tourniquet. Any other precaution apart from not tying tourniquet? Hydration status should be fair. Dehydration spuriously increases calcium level. That is one another thing.
Okay,
and
sir.
we should be mindful of albumin levels that we all know, right? Fine. And the measurement should not be, this semi-automated measures of measuring calcium is totally not worthy. That Colip measurement, that's how they measure in semi-automated calcium monitoring, but that's very error-prone. If possible, you have to have an automated calcium measurement.
Okay,
That's
sir.
a relevant thing. Next. I've taken too much time. You can proceed to next slide.
Sir, since patient had a seizure, we gave injection levetiracetam 500 mg administered IV as a stat dose, and we started up etiological workup for severe hypocalcemia, sir.
Okay.
So approximately after 1 hour seizure episode, patient suddenly became unresponsive and developed profuse sweating, and the patient GCS was 8/15. Pupils were bilaterally thin and reacted late. So severe hypotension was noted, and with tachycardia. And so we in view of a
One,
poor
one query. Before the patient developed the thing, have you figured out hypocalcemia by then, or it was figured out only later?
no, sir, we were waiting for lab, sir.
Okay, so it was not
Typically,
found. That's why the patient has gone in for okay. Fine. I
yes,
was
sir.
wondering why the patient landed in complication when we have already find out the diagnosis. Okay, fine.
Within 1 hour, a patient went into
Yeah,
shock.
yeah, I understood.
So patient was intubated and inotrope support was started, sir. And a progressive improvement was in dynamic status, hemodynamic status was observed. Noradrenaline infusion was gradually tapered and discontinued within 24 hours. Serum calcium levels improved with ongoing IV replacement. Sensorium improved. So vasopressor requirement was resolved, sir. Sir, patient was successfully underwent gradual ventilator weaning and extubated. Later developed features suggestive of aspiration immunities. So IV hydrocortisone was given as a supportive treatment, sir. Respiratory status improved, serum calcium normalized, and patient remained hemodynamically stable without further seizure episodes. And this was the initial lab values of CBC, sir.
If there is any positive finding, you could highlight. Otherwise, you can move on.
Okay, sir. LFT were normal, so with the albumin and the protein levels were within limits, sir.
Expecting
And
anything in the LFT?
So the albumin levels should be, if it is directly because of calcium ions.
Fine.
Calcium albumin protein.
Any other
bound,
thing in LFT that you should be worried about in a patient with calcium metabolic disorder, apart from albumin? ALP, alkaline phosphatase, predominantly bone origin.
bone hemostasis could be altered.
Yeah, there's a saying bone burns. I mean, it's probably in olden times, it did not in my time. Previously, they used to find out about the bone ALPs, because when they burn the sample, the bone ALP will get the sample ALP contribution from the bone will disappear. So that's how they differentiated the ALP, whether it's from bony origin or from any other origin in the past during lab chemistries. So that
Okay, sir.
gives to that proverb, bone burns.
Okay, sir.
Excellent.
RFT, urea creatinine are normal, sir. Regarding sodium and potassium, initial values were within limits, sir. Subsequently, after weaning off from the ventilator, patient had a developing hypokalemia, sir.
Why?
Sir, actually, we treated the patient with the hydrocortisone, sir.
100 milligram TDS. That is the
Yeah.
dosage, right? That doesn't usually cause hypokalemia.
Yes, sir.
Anyway, proceed.
So these were the serum calcium, magnesium, phosphorus values, sir, from the initial admission status.
Any precaution to be taken for phosphorus collection, serum's phosphorus? Calcium can be collected at any time of the day. Whether the patient is in fasting, whether the patient is sitting or standing, it doesn't change. But phosphorus, there are certain precautions to be taken again. Do you think of anything? What are the precautions to take a phosphorus sample? It has to be done in fasting. Why?
Fasting sample, sir.
Why? Because when you take food, what happens to the insulin levels? Insulin levels will go up and it might spuriously lower phosphorus level. That's why we have to do it in fasting state. It has to be overnight fasting for 8 to 10 hours. And unlike calcium, there is a diurnal variation for phosphorus. Phosphorus, it's again a beautiful molecule that is determined by FGF23, PTH, and the interaction of these molecules with the kidney. So they just like a hormone, it has the diurnal rhythm. More in the fasting, more in the morning hours rather than the evening hours. So it has to be taken in fasting in the morning sample, preferably in the morning sample. Fine.
Okay, sir. The initial serum calcium was critically low, sir. After correcting the calcium over infusion and supplement with the calcium oral supplementation, the calcium levels were improving initially, but subsequently the patient refractory in the hypocalcemia was reported, sir. So after 3 days, again, the patient went into sudden cardiopulmonary arrest while admitted in the ICU. After the resuscitation, the
Why?
patient
Because the calcium has improved. Why did the patient went in for cardiopulmonary arrest?
unknown.
Unknown cause. Right. Right. It was 8.8, no, on fifth. How come it dropped to 5.5? Lab error, right?
No, sir. But
But when
refractory
you are
patient was
infusing
given.
calcium through a vein, probably the intern might have taken the same hand, the sample. That's why it might have reached 8.8. Otherwise, there is highly unlikely that it would have reached such a high value in 2 or 3 days. You don't get that kind of values. Fine.
Yes. So again, patient went into arrest, sir. We resuscitated the patient, and again, the patient went into shock, and inotrope support was given, and with ventilator support. ECG, IV, actually, sir, potassium hypokalemia was recorded during this episode. So IV potassium replacement
It
was
was
initiated with.
dropping all along and it has dropped to a critical level, right?
Yes, sir.
Any other cause of hypokalemia that was found in this patient? Apart from theoretical risk of hypokalemia with hydrocortisone, which is definitely not there. Can you link hypokalemia with hypocalcemia? Any way of connecting these two?
Hypomagnesemia is another cause, sir, underlying cause,
Why
which could connect to the
hypomagnesemia?
hyperkalemia and hypokalemia and hypocalcemia, sir.
How? Hypomagnesemia can theoretically cause hypoparathyroidism and it can precipitate hypocalcemia. But what is the link between hypocalcemia and hypokalemia? I don't think it.
No, sir. No, sir. No, sir. I meant hypomagnesemia can cause hypokalemia, sir.
How come hypomagnesemia occurred in this patient? Anyway, I mean, good guess, but probably hypoparathyroidism can also lead to hypomagnesemia. But again, it's a two-way road. Hypomagnesemia can lower PTH, but whether the reverse is true or not, we are not sure. But one another way how we can connect this hypocalcemia with hypokalemia is there is a condition called type 5 Bartter. Does anyone know? Bartter syndrome type 5, which has autosomal dominant hypocalcemia. CASR gain of that calcium sensing receptor gain of function mutation might be there. It's actually quite common in general population. So many of those post-surgical hypoparathyroidism patients, they might have pre-existing some form of gain of function mutation CASR. These patients have some form of Bartter syndrome, type 5 Bartter syndrome, or any patient who has persistent long-standing hypocalcemia can actually present like a Bartter-like condition. We did have one patient recently, hypocalcemia due to post-surgical hypoparathyroidism resulting in long-standing diarrhea, presenting with a Bartter-like hypokalemia-like picture with muscle weakness. When we corrected hypocalcemia, hypokalemia got corrected without even necessitating this potassium replacement. So, either a congenital type 5 Bartter or an acquired Bartter-like condition due to long-standing hypocalcemia can result in renal-mediated kaliuresis. So that is one way of explaining. But again, that is not the explanation in your patient because it's of only 1 year duration. I don't think that can happen so soon. Anyway,
Okay, sir.
fine. Proceed.
So IV potassium replacement was initiated with the injection potassium chloride administered at 125 ml per hour under continuous cardiac monitoring. Serum electrolytes were sent urgently and subsequently confirmed a significant hypokalemia. So oral potassium supplementation was ordered in the form of syrup potassium chloride. And following aggressive correction of electrolyte abnormalities and supportive management, patient remained hemodynamically stable with no further episodes of cardiac arrest. This was one of the ECG taken after the cardiac arrest.
You want to highlight anything in this ECG?
Sir, U-wave presence.
You have seen. Okay, hypokalemia. What other ECG signs of hypokalemia? You should teach me.
Prolonged peer interval, U-wave, sine wave pattern in critical hypokalemia, sine wave pattern will develop, sir. Oh,
and speaking pattern. No? In hypokalemia, hypokalemia, there will be dipping of this ST segment. And
T wave inversions. Sir, in easy hypokalemic changes, there will be low amplitude T wave, sir, and a prominent U wave or apparent QT prolongation or T wave inversions.
merging of these two waves, T and U. Right.
Frequent PVC.
Okay, fine. You can proceed.
PVC arrhythmias. Sir, these are the serum electrolytes values of this patient, sir. After cardiac arrest, and this hypokalemia correction was done, and the patient got the values corrected, sir. So urine electrolytes value, sir. Patient have a urine sodium and urine potassium loss, sir.
How did you figure out that the patient has urine potassium loss? With urine potassium value, or did you do some other thing?
Urine potassium sodium value, sir.
Is there any cutoff to say that patient has urine potassium loss with random urine potassium sample?
More than 20, sir. In sodium, urine sodium more than 20.
What does Harrison say? So I remember there is a hypokalemia flow chart, no? Working algorithm is there. What do you do? What is the first step that you do? First investigation that you do while assessing hypokalemia? How can you say that there is calurisis? It's not based on random. Anyone? What other parameter that we
Urine
should along with
potassium gradient
to
ratio.
say that? Yeah, Sarah has answered. Transtubular potassium gradient is there, no? TTKG. So to measure that, what do you need? Apart from urine potassium, what do you need? Transtubular potassium gradient.
Okay, sir.
Hey, you know, okay.
Asking a question. You have to answer it.
Urine osmolality.
யாரோ போட டிடிகேஜி யார் சொன்னது?
அருண்குமார் சார்.
Our registrar, Arun Kumar sir. He has become PG.
Hey, actually, PG, sir is asking a question. It's not informing
Serum
you. You have
osmolality
to
and serum
answer the
potassium
question.
to say that.
What are the other components of TTKG?
Sir, நீ ஃபைன் சார். தம்பி ப்ரொசீட் பண்ணலாமா?
சரி போடு சொல்லு. அசிடோசிஸ் பார்த்தியா தம்பி? ஏபிஜி பண்ணியா?
எஸ் சார்.
ஏபிஜி என்ன இருக்கு? முடிச்சிட்டான்டா.
இல்ல சார்.
Project the ABG value.
1 second. Yes, I will project, sir.
Why urine calcium was done?
One second, sir.
Okay, no problem. You continue, don't problem. Continue.
Okay, we proceed with the
ABG interpretation you say, need not present the slide.
Okay, sir.
என்ன இருந்தது ABG ல சொல்லு.
சொல்லுடா சும்மா சொல்லு. ஏபிஜி நார்மல் தானா? இனி அசிடோசிஸ் ஆர் அல்கலோசிஸ்?
So one second, I got the results. One second. Sir,
What is-
alkalosis. The pH of 7.4 and bicarb 27.13, sir. The alkalosis, sir.
So hypokalemic alkalosis, hypocalcemia, hyponatremia also there. So all electrolyte is imbalanced.
Yes, sir.
The possibility of RTA?
It was alkalosis, sir.
Alkalosis அப்ப பாட்டர் தான்.
Coexisting RTA.
சார் பாட்டர் தானா சார்?
Butter.
தெரியல சார், அதான் மோஸ்ட் பாசிபிள் எக்ஸ்பிளனேஷன். ஆனால் இந்த இவ்வளோ ஷார்ட் டியூரேஷனில் வராது சார். வாட் இஸ் ஆக்கம்ஸ் ரேசர்?
இருக்கு hypocalcemia. But periodic hypokalemic periodic palsy Porter syndrome is one of the differential diagnoses.
Hello.
Sir.
Tell Raf.
Yes, proceed,
Proceed.
Okay, sir. So we took calcium random urine values, sir, which is normal, and we took PTH
Why was it
hormone
done? Why was it done?
to rule out Barter's only, sir. Hypercalciuria condition, whether it is a hypercalciuric.
Okay, but I don't think it's useful in this current setting.
Okay, sir. So PTH hormone level was less than.
Obviously, when PTH is a very notorious molecule. What are the precautions to take sample for PTH? In endocrinology, there are two cruel molecules. One is PTH and
Proceed,
another is ACTH.
So your connection is not good.
PTH would be immediately taken in cold chain, sir.
How do you maintain that cold chain? Routinely, I get values of these things done by various patients because of health packages and other stuff. That is one. Send the patient to me. Can anyone say what is the cold chain maintenance in PTH measurement? Is my audio clear or I am breaking?
No, sir, you are clear.
Sir.
No problem. Any other PG can answer the question raised by moderator, sir? Bhagavadiyapan, are you there?
So PTH is a peptide molecule, no? PTH and ACTH
Yes.
are peptide molecule. The cold state, the cold chain maintenance, actually what we say is we have to use a pre-chilled syringe and use a pre-chilled EDTA tube. Then we have to collect the sample and there's a cold centrifuge is a different kind of machine that we use for measuring these molecule. Of course, in I don't think in our locality cold centrifuge kind of centrifuge machine, then they have to. Can proceed.
Okay, proceed, Napoleon.
Yes, sir. Yes, sir. So next, calcium creatine ratio was taken, sir, which is found to be normal value, sir.
Again, in this, I don't think in this, in this situation we should be doing urine calcium and creatinine ratio. Probably in follow-up time we have to do this urine calcium creatinine ratio just to ensure that we are giving enough amount of calcium and not too much of calcium. Not useful in this patient.
Okay, sir. So thyroid profile, TSH was elevated. Thyroid profile was taken, sir. TSH was elevated, so patient was supplemented with the thyroxine 150 micrograms. CT brain normal findings, sir. And MRI brain was taken normal study of the brain parenchyma, and EEG normal study, sir. So expert opinions were obtained. So cardiology opinion obtained, and it revealed a mild left ventricular systolic dysfunction with an EF of 45%, and advised for enalapril and metoprolol after the stabilization of hemodynamic status. And anesthesiology opinion obtained regarding ventilator settings only, sir. And radiation oncology opinion obtained, and opened to continue the same treatment. And a general surgery review was taken.
Drop in ejection fraction to 33%. What kind of cardiac involvement that you see in hypocalcemia patient? There's a drop in ejection fraction. Why is it happening in hypocalcemia?
So it is essential for a contraction and excitation coupling in the cardiac muscles, sir. Oh, sir.
Again, if I have to go to that calcium paradox, if you have to go by calcium paradox, you should not be, there should be too much of contraction of myocardium, right? Because other tissues are hyperexciting. Why cardiac muscle is getting depressed? So you find out the answer for this, and if possible, let me know. We get dilated cardiomyopathy, but this is one another paradox. that doesn't fit into calcium paradox, but there is an explanation for that. It's interesting if you could just go and read and find out.
Okay, sir.
And the
So in view
reversible
of
cardiomyopathy, usually with the hypocalcemia correction, it completely recovers.
okay, sir. So in view of refractory hypocalcemia, she was started on tablet calcitriol, 0.5 micrograms 4 times daily, along with oral calcium supplementation, 300 milligram 2 TDS. Following initiation of therapy, serum calcium level stabilized above 7 milligram with the normalization of urinary calcium excretion. The patient is currently hemodynamically stable and maintaining adequate serum calcium levels, free of further seizure or cardiac events. Hence discharged and under regular follow-up, sir.
அதாவது ரெஃப்ராக்டரி ஹைப்போகால்சிமியா இருக்கிறதுனால நம்ம calcitriol ஆட் பண்ணல. ஹைப்போபாராதைராய்டிசம் பெர்சே நீட் calcitriol. Without that, we cannot manage any patients of hypoparathyroidism. That is probably biggest drawback in our institutions, because calcitriol is not available. If I'm right, is it available in your college?
No, sir.
Generally, it's not available. So most of the time, patient has to buy this from outside. The major difficulty in managing hypocalcemia in government setup is the absence of calcitriol. Without calcitriol, you cannot manage any patients of hypoparathyroidism. Hypocalcemia will never get corrected. Why?
Sir, activation.
You need PTH for conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. The 1-alpha hydroxylase enzyme in kidney is actually aided by PTH. Without PTH, that doesn't function.
Yes, sir.
So you have to give calcitriol. Without active vitamin D, you can never correct. Probably if calcitriol has been added as early as day 2 when the patient was taking oral feed, most of the time the patient never lands in any complications. And yeah, probably we might have started and just yeah. And there is a catch in oral calcium supplementation as well. Can you tell me the dose of calcitriol and elemental calcium in patients with hypoparathyroidism? Anyone? Weight-based dose?
Sir, for elemental calcium, 40 to 60 milligrams per kg per day, sir.
Okay.
For calcitriol, 40 to 60 nanograms per kg
per day. Yeah, roughly. Some text says it's 20 to 30. Some say it's 40 to 60. In adult, usually the requirement is around 0.5 to 1 microgram total calcitriol, and elemental calcium from 2 to 4 grams is the usual requirement. And while giving calcium supplementation, since it's a 300 milligram elemental calcium, right? What is the maximum number of calcium tablet that you can give at one point of time?
2, sir. 2 TDS. Actually, I gave 2 QAD TDS.
No, what is the maximum amount of elemental calcium that you can give at one point of time? That is very important. Since this is a hospital supply, right? That is why you are giving 300 milligram 2 tablets. If you are using that private tablets which contain 500 milligram elemental calcium, actually the maximum amount of calcium that can be given at one point of time is 600 milligram. So if the patient, if you are planning to give nearly 4 grams of calcium to the patient, it has to be split evenly. You cannot give 2 tablets like how you have given. In your case, it's okay because the elemental calcium is only 300. But when elemental calcium amount goes up, you should not be giving 2 tablets at a time. Most of the time, we use this calcium carbonate preparation that contains 500 milligram or 400 milligram of calcium. The ESI supply has 400 milligram and the private tablet has 500 milligram. So you have to give 1 tablet at one point of time. You cannot give more than 1 tablet. When you are giving 5 or 6 tablet, you have to split it evenly. And for absorption of calcium carbonate, you need to take it after food because you need HCl for absorption. So patient has to take some small feed, and after every small feed, they have to take 1 tablet. On top of that, patient will be taking thyroxine in the morning. Calcium carbonate cannot be given with thyroxine. So patient need to take thyroxine in the morning, wait for 4 hours, start taking calcium tablets at 11 a.m. in the morning, first tablet, that's how we give. Then after lunch, then after evening tea, then after dinner, then after bedtime milk, we have to give 1 tablet after small feeds. So that's how we correct. And it's a very tedious and probably highly irritating work for the patient to take tablets in such a way. When you give 2 tablets at a time, it never works because it tend to neutralize gastric pH. When you give too much of calcium carbonate, the localized acidic environment will go. So it will never get absorbed. So you have to give only one tablet.
Okay, sir.
And why I'm highlighting this thing is that hypocalcemia is very rampant in routine practice. Most of the thyroidectomy that has been done in our part of the world is quite useless. There is a routine practice to do thyroidectomy for anyone with goiter. Please differ from that practice because we are getting a lot of patients with the hypoparathyroidism. Once you land in hypoparathyroidism, literally your life is gone. The quality of life will be terrible despite all the treatment. And the patient might be seizure free, but if you ask how she is, she will always complain of aches and pains. Iatrogenically inducing such hypoparathyroidism for anything less than non-malignant thyroid condition is totally not worth it. So we are getting more conservative regarding this thyroid surgery. If the patient doesn't have nodule, please don't do any FNAC. Anyone having a generalized goiter, please don't even do an FNAC. And if you are planning to do an FNAC, it has to be taken from the nodule, ultrasound guided. And only when the FNAC shows malignancy, you have to refer the patient. When the TBSRTC category is more than 4, you have to refer the patient for surgery. Rest of the patients, better not to refer the patient for surgery. Thyroidectomy worldwide, it's a menace. Most of the thyroidectomies are useless. At least save yourself and family members from useless thyroidectomies. Fine.
Okay.
Is it over?
Yes, sir.
Thank you, Napoleon. Arun, do you have any slides to discuss with the PGs? Right. Okay. So thank you, Arun, for coming up with an excellent discussion, and thank you, Kanan sir, also for having a good discussion with the postgraduates. Over to our HOD sir for concluding remarks.
Thank you, Dr. Arun Vishwanath, for a wonderful discussion. Usually, this endocrinology is a raw area for physician. PGs will not bother to read a lot about this endocrinological area, and especially this calcium, phosphorus, magnesium. Usually, nobody will bother to read and understand. But this session has thrown good amount of light over this endocrinological case, especially this calcium metabolism. And the way you taught the points, really I loved it. Especially the samples, how to take samples, how to read laboratory values, what are the pitfalls in laboratory values, laboratory error. And since your wife is biochemist, you got
No, sir. Actually, probably she may not be able to tell all these things. In most of the endocrine interviews, they used to ask this, sir. If you, previously there used to be in interviews, right, in PGA and AIMS, when you clear the exam, only in interviews they used to ask only these things: how to collect sample, what are the precautions to take. That's why we know all these things.
Anyhow, it's really a wonderful session. I learned a lot about this calcium phosphorus metabolism and the practical points in this case of calcium. So thank you, Dr. Arun Vishwanath and Kannan. Thank you very much. The initial part of discussion was really helpful and informative for the PGs. Thank you, Dr. Kannan. Thank you, Dr. Napoleon. It's a good presentation. Keep it up. You answered all the questions very well. And thank you. And thank you all other PGs. Thank you, Registrar Dr. Arun Kumar, for arranging this wonderful session. Thank you.
Thank you.
Thank you.
Thank you all. We can disperse and we will meet up in the next interdisciplinary forum. Thank you. Thank you, Arun.
Thank you,
Kanan sir.
Thank you.
Thank you.
அவர்கிட்ட பதில் சொல்றோம்.